So, today I wanted to focus on the cross-sectional anatomy of the chest, abdomen, pelvis, in particular with iodinated contrast. These slides that you see in front of you are my own personal slides. However, you are welcome to take screenshots or whatever you like with them, but please be mindful that these are mine. So if people do ask you where you got them from, I would much appreciate it if you told them that you got it from me. Now, before we get started, CT physics, very basic rundown, or more so the CT workflow, I should say. Before we begin any CT acquisition itself, we take a quick topogram, a quick scout, a quick scanogram of the body of interest. So every vendor has their own way of going about things. Every vendor has their own way of doing things. So what do we do? So the CT scanogram or topogram gives us an indication of where the region of interest is. It tells us the top and it tells us the bottom. And this pink box is often what we use to indicate the top and the bottom of our scan range. I work predominantly with a Siemens CT scanner, so you might hear me say topogram a lot, but topogram, scout, scanogram, they're all really the same thing. You would have hopefully recognized that I didn't say the word projection. The picture in front of you is not a projection. We can call it whatever we like, but it's never a projection. The reason is this image is not a point source image. The table moved as we did an acquisition. So this image is essentially multiple different locations of the patient stacked up on top of each other. So this is a topogram and not a projection. Just be mindful of that. In this example, the region of interest is obviously the chest. Contrast media is an important aspect of CT imaging. You will often hear that MR is superior to CT, and you have to be careful of how you word that statement. Every modality has its pros and its cons. The CT itself has pros over MRs for certain things, and vice versa. To help CT become more, easily accessible, but also more beneficial, we often give contrast. Now, contrast itself can be given through various means via a cannula in the arm for intravenous contrast. We can give it orally. We can also give it subcutaneously if we need to. We can also give it rectally. So there is lots of different ways that we can deliver contrast. But the purpose of contrast is to actually replace whatever was there with contrast. So in this example, the aorta is in the middle here, and we can see it really bright and really well because the contrast has mixed up with the blood in this location, and it's changed the physiological attenuation of contrast. So the blood contrast in this region here has a higher Hounsfield unit because it attenuates the X-rays a lot more, as opposed to the image on the left here, where it's essentially the same location, the same structure, and you can probably make out that this is the aorta. But this location has only blood, so blood itself doesn't attenuate X-rays as well, so it has a lower Hounsfield units. The more attenuation it is, the brighter it looks on plain film and on CT. So like on X-rays, black is predominantly going to be air-filled, and white is predominantly going to be a structure that is quite dense. So often we associate that with bone, but on CT, that is often also contrast. Without the contrast, through the liver, hopefully you can appreciate that we can't make out this lesion, this irregular border lesion, and this regular border lesion. The reason why we can see this lesion is that the contrast that we gave the patient is now inside the lesion. It's filling up the blood vessels and the different blood-filled vessels of the lesion, and that makes this region more attenuating, and therefore it is brighter on x-rays. Hopefully something else that you can appreciate is that these two images, although they are of the same region, they are technically different because this image is a little bit grainy. Hopefully you can appreciate that the image on the right is a little bit more smooth, almost like plastic-like. The reason why this occurs is that the image on the left-hand side is a thin slice, and the image on the right-hand side of the screen is a thick slice. So in radiology, we often produce two data sets, a thin slice and a thick slice, and various different reconstructions in different body planes. We often will need to produce thin slices. The reason is, without producing thin slices, there is a chance that we're actually going to be missing information. So that's called partial volume artifacting. But because there are thinner slices, or in other words, because the information isn't as thick, so imagine going from this thickness to this thickness, the computer has less information to produce this image. So every slice on the thin has less information as opposed to the thick. So therefore it's more noisy. There isn't as much information, so there's more quantum noise, and that's what this pixelated hazy appearance that you see through the liver and the spleen is. So just be mindful, to summarize this slide, is that contrast makes the attenuation greater. It also means that the Hounsfield unit is higher, and therefore your image with contrast is often a bit brighter. Hopefully you can also appreciate that the general appearance of the liver is a little bit brighter as well. That is because the liver has picked up some contrast, making it a little bit brighter. And if you're interested, this is a early arterial phase of the liver. Alright, so like I mentioned before with the slice thicknesses, every single slice that you see, every single CT data set that you see is a representation of a 3D set. So we could sum up this slice as everything that is in between these two blue lines. That is why we've got to be careful that we don't make the slices too big. If we make the slices too big, we could potentially make a small lung nodule appear as a larger one. What I mean by that is, imagine a small lung nodule in between these two blue lines. So this particular slice will represent this lung nodule as one pixel over this slice. But if we made the voxels in this direction bigger, that single nodule may be overrepresented, and it may seem like it's quite a large nodule when in fact it's a tiny little one that, due to our slice thickness, has been dragged across the entire slice. That is why it's important that we always send for reporting the thin slices and the thick slices. Often in packs we would send the thick slices, and if we don't report off packs to the radiology reporting stations, we will send the thin slices as well. In this day and age, more and more places are foregoing the separate server for the reporting station. The reason for that is data space now is so cheap and so readily available that almost every pack system you will send the thins and the thicks. There is almost no reason why you should be so stingy with your data space when the thin data set doesn't make up a huge amount. In the old days, we were very careful with how many slices and how thick the slices were, because you had to print onto film. And the more slices you had, the more things you needed to print, and the more sheets of film that you use. And film costs money. The more films you sent out, the more money you were costing the department. So that mentality was brought across to digital packs. But nowadays, with more and more packs being so easily available, this mentality is hopefully going away. But some radiographers, when you go to a CT rotation, might be very pedantic about the number of slices you send to packs or how big your window box is. In my personal experience, I'm not as pedantic because I'm not from that generation, but the CT supervisor that I work with can be a little bit pedantic in that regards, but obviously everyone to their own. But in my personal opinion, it doesn't make a huge difference at all. Now, that was the preamble for CT. We are going to move relatively quickly now through the rest of my presentation. The next many slides is going to be slices of CT data, and then I've labeled them accordingly. So if you feel like taking a screenshot, please feel free, but I am going to be moving pretty quickly through this presentation, okay? So the first slice is of a CT chest in the arterial phase. I like this particular slice level, and I've indicated on the topogram there where we are. This is a good place to start your learning because the aortic arch there has this classic appearance. It covers almost the entire mediastinal compartment, and it has this fantastic shape that a lot of my junior staff grade 1s call find the sausage. So when they are teaching the students or showing the students what they're referring to, they will say find the sausage. So the aortic arch has this beautiful appearance here, this nice vertical white shape, and then next to it is the trachea. Because the trachea is an air-filled structure, it is black. The trachea, as opposed to the esophagus, brings vital air into your lungs to be exchanged by the alveoli. So the trachea is almost always a perfect cylindrical shape because it is not easily collapsible. If you can imagine, if your trachea collapsed easily, you would not be breathing very well. So a nice round structure in the middle of your chest is most likely going to be your trachea, your left lung, your right lung, and in essence, I have labeled the rest of the structures with a very similar color scheme. Arteries are always red, veins are always blue, muscles are always orange, and miscellaneous stuff are always green. We are now going to be moving down towards the feet first. No, sorry, we're going to be moving first towards the head first, and then later towards the feet. So just before we move up, you can see the SVC there as well. The SVC is filled with contrast because we inject into a vein, and we normally inject into the upper arm veins, so either in your brachiocephalic compartments or sometimes through a port, so that will inject directly into your SVC sinoatrial junction. This little structure that's coming around the side here has a little bit of contrast in it, and that is reflux of contrast from the SVC into your azygos vein. So that's very common as well to see reflux into your azygos vein. Now, moving up towards the head, you see your aortic arch start to bifurcate into those common appearances that you see. The aortic arch is in the middle here, your brachiocephalic artery, your left common carotid artery, and your SVC, left brachiocephalic vein, etc. I've also indicated this patient has a indwelling chest port, which in this case we injected contrast into. Something to note is that in a normal body, in a normal anatomy body person, veins will usually cross the midline from the left to the right. So if you see a structure that is from the left-hand side of the body moving over the midline to the right side, it is most likely a vein. So this structure here is reflux or backflow from the SVC into the brachiocephalic vein as well. Moving further up into the chest, wrong way, into the head, you see a bit of the aorta, you see the left subclavian artery, the left common carotid, your brachiocephalic artery, your right brachiocephalic vein, left brachiocephalic vein, some surgical clips, you see contrast in your port, and you see part of your clavicle and more contrast as well. Remember, your brachiocephalic artery will eventually bifurcate into the common right carotid artery and your right subclavian artery, as similar to the left side, and likely your common carotid artery will eventually bifurcate into your external and internal carotid arteries on both sides. So moving up further, you see this beautiful white thing here. This is contrast in the port. This contrast is 100% contrast. This contrast is very, very, very dense, and so this is why it's causing this streaking artifact across your image. The computer is very confused as to what information is meant to be there, so it has this issue where it causes these straight lines through your data set. You see your muscles of the shoulders here, infraspinatus, supraspinatus, and your subscapularis. Remember, your subscapularis is sub meaning behind. So if this is your scapula, it is behind your scapula, but in front of your posterior thorax there. With the streak artifacts, this is the reason, a lot of places do a saline bolus chase. So what is a saline bolus chase? A saline bolus chase is a technique where you inject contrast first, and then you follow that immediately by a bolus or a run of normal saline. And what that does is it has three rationales. The first rationale is it keeps the contrast moving at a constant rate, because the moment you stop the contrast injection, that contrast will start to be more easily broken up by the normal blood and diluted by the normal cardiac output. The second reason why the contrast, saline bolus is convenient is that hopefully by the time a saline bolus comes through this region, it is when we are doing our image acquisition. So if that is the case, we have the contrast still moving through really well, but you have very little to no contrast streaking through your axillary region, because the thing that's pushing the contrast through is actually saline and not contrast. So therefore you have little to no contrast in the port, so therefore little to no streaking through this region. And the third reason why giving saline is very convenient is it also gives patients a saline flush. So we've actually flushed our line as well, but also it's to help hydrate the patient post the contrast injection. And lastly, you will note that this is an air-filled structure. The only other thing that's air-filled that is normal in the midline besides the trachea is the esophagus. You can see how different the caliber of the esophagus and the trachea is. Remember, the trachea is a very important air-filled structure that takes air from our outside to our lungs to be exchanged. So it needs to be patent and open all the time. But our esophagus, because it's just food, and with gravity food falls, and along with the peristalsis movement, it doesn't need to be open all the time. So don't be tricked by some radiographers asking you if this is the esophagus. It is not the esophagus. It's too large to be the esophagus. If the esophagus was this large, it most likely will be held open by a stent, or the patient has had some surgery For example, an Ivor Lewis esophagectomy, where they've done a stomach pull-up and put part of the bowel here or part of the stomach here, which can remain quite open if required. Moving further up from that slice, you have this appearance. This is the left subclavian artery and the left common carotid artery as well. The right common carotid artery and the right subclavian artery. Remember that your carotid arteries come from a common space, and that these eventually will head up the neck and into the respected areas in the face and in the front of the brain. Remember, your vertebral arteries is what supplies the posterior aspect of your circle of Willis. Your axillary vessels are seen here. Something that I really dislike is if someone tests a student and doesn't allow them the ability to scroll up and down. I think it's very important that when you are learning that you take charge, grab the mouse if ask them, of course, and scroll up and down to see which direction those vessels are heading. Remember, your subclavian artery is just another name for the same vessel that eventually becomes the axillary artery. So because the arm is a multifaceted region with lots of different components, it is not uncommon, of course, to see the axillary artery and the subclavian artery in the same plane. And similarly, you can see the same thing there for the left side as well. So my advice is, if you were to be reviewing CT slices, it's in your best interest to scroll up and down and to follow the vessel, because when you learn your anatomy, you learnt it as one picture from top to bottom. The ability to see it up and down might help you identify it in a more convenient way. Moving further up, you can see that your vessels again are indicated there. You can see some lung abnormality, the lung pathology on the patient's right lung there. I've called it lung pathology because it could be a multitude of different things. It's uncertain as to what it is because it's irregular in shape. If a patient didn't have any other clinical indication, they might do a biopsy on that if they think it's warranted. The left-hand side there is a lung nodule. I'm calling it a lung nodule because it's well circumscribed. It has a very nice border. It is small in nature, and this one here is attached to the chest wall, so it most likely is a lung nodule. In this case, if this was the only thing the patient had, the clinicians might monitor this for quite a number of years in case there are issues or it gets larger, etc. As you move further up towards the head, you can start seeing the left and right lobes of your thyroid. Your thyroid lobes will join in the middle at the isthmus. You can see how beautiful the thyroid has picked up the contrast. One of the most important questions to ask when you do a CT scan for the patient is whether the patient is receiving any thyroid treatment. The reason is very apparent there. Even with this very short amount of contrast injection, the thyroid has lit up very well. That is because it readily picks up the contrast, but does not regularly or easily excrete the contrast. So a patient who has had a thyroid who has had a CT scan, depending on the type of thyroid treatment they're having, may not be able to have that for up to 6 to 8 weeks. So it's very important that we make sure that we ask that question to not completely bugger up the patient's treatment schedule. Something that you probably should be aware of is that in radiology / nuclear medicine / radiation therapy, it's very important that you as a medical radiation practitioner learn and know about each other. It's not good just to be a radiographer. You should be a knowledgeable radiographer who knows about the other professions, because it helps with your own learning, but also helps with your own management and treatment for patients. So in nuclear medicine, there is a particular test called iodine 131. This test uses iodine, and iodine goes to the thyroid. So if you give the patient a load of contrast injection, that will go to the thyroid, and the thyroid may not pick up the iodine 131 very well, if at all. So therefore, the patient has to wait X amount of weeks until it is deemed safe or effective, for the patient to have this treatment. So just be mindful of that, is that I encourage you throughout your working life career to make sure that you learn about each other, the radiation therapists, nuclear medicine technologists, etc. So make sure that you can further your education as well. And there it is, the isthmus of the thyroid. Alright, so hopefully you guys didn't think that I was just going to spend 2 hours talking to you. I would like you to go to menti.com, menti.com, and then I will give you the code if you don't have it already, and we are going to do a little quiz. This is a competition quiz. I am pitting you guys against each other. There isn't a lot of you guys in here today, so this shouldn't take too long, but hopefully you guys have some fun out of it, and hopefully you guys have been able to get something out of it. Okay, so let's continue the presentation now. We're going to start at this position first. Again, this is my favorite position because you can see a sausage there. And we're going to move further towards the feet this time. So as we're moving down, you see all those lovely structures that we mentioned before: the esophagus, trachea, azygos, vein, SVC, aortic arch, descending aorta, spinal cord. There's some little blue arrows at the top there. Those are your lemurs and your remus, or these days often called the thoracic arteries. They're very important for breast reconstruction and reconstruction of that kind of region. The reason is they're a good vessel blood supply to your flap or reconstruction region. So often remus and lemur CT angiograms are quite common. You'll probably get some DIEPs, your deep inferior epigastric perforator artery CTAs as well, again for similar reasons. Or you might even do a CT angiogram of the leg, so often called a leg runoff, for the same reasons, to see if there are any tibial or deep femoral flaps that they can use that will help with the reconstruction. Again, this is still the arterial phase, so you should be able to see the arteries quite well enhanced. And we'll move further down now. As we move further down, the aortic arch will separate, or not separate, but it will appear as if there are two aortas. But just be mindful, it's the same thing, just shown differently on different parts. All right, moving further down. Moving further down, you can start seeing the pulmonary trunk appear. The left side is often more, the left side is often visible first because the heart is quite high and it sits on the left side, so it pushes everything up. So often you see the left side first. You also start seeing the trachea bifurcate into the left and right main bronchus at the level of the carina, and we'll move further down now. You see the pulmonary trunk there. You see the left and right pulmonary arteries coming through there. Now, at this level, I need to remind you that it is important when you're learning to maybe have a diagram of the heart out in front of you, because it's very convenient if you understand where each of these vessels come out of and where do these vessels enter into the heart. And that will actually help you identify the heart chambers. So we know that the contrast, or the blood, first enters the heart through the right atrium. The right atrium then communicates with the right ventricle. From the right ventricle, blood is then taken to your lungs via the pulmonary trunk. Blood from the lungs is returned back to your heart via the pulmonary veins. The pulmonary veins enter your heart via the left atrium. The left atrium communicates with the left ventricle, and then the left ventricle sends oxygenated blood through the aorta to the rest of the systemic circulation. So, as we move further down, we should start seeing those structures. And when you're learning, it might be a useful learning tool to have that structure in front of you to help you identify things as you move down. And again, there's nothing wrong with following one thing at a time. So if you find it difficult to follow all 5 or 6 structures at once, just pick something and follow it up and down until you feel comfortable that you know what it looks like, where it's going, and the name of it. So, moving further down, very similar to the previous picture, except you see that there is a small left pulmonary vein come through now. The pulmonary veins are paired on each side, so you have 4 pulmonary veins, the left and right pairs, and they enter the heart via the left atrium. And the pulmonary trunk, the main pulmonary trunk, comes out of the right ventricle. So we should start seeing those structures as we go down. Again, very similar to the previous structure. Now, I've labelled the left atrium there. I've labelled that as a left atrium, but I don't expect you to know it from this picture. Again, please scroll up and down to make sure that you are saying the right things and you're labelling things correctly. You can see there that the left pulmonary vein is very close to the pulmonary artery, and at this point you no longer see the left pulmonary artery. Alright, moving further down, and you clearly see here that the left pulmonary veins have entered the heart via the left atrium, and that is indicated there. Now, the pulmonary trunk, like we indicated before, comes out of the right ventricle, so we'll see that very shortly. The left atrium will join with the left ventricle, so the left ventricle, again, we'll see that very shortly too. Alright, this is a very common cardiac position because we can see the left main coronary artery origin there. The white arrow often is the position of the right main coronary. The left and right coronary arteries can appear above or below or in a different position off the aorta. There's nothing fixed, but in general, they're the general locations that in my experience you find them. The left main coronary becomes the left anterior descending, the LAD, and then the LAD forms your diagonals. Your right becomes the right coronary, and then your marginals. The pink arrow points to a location. If your left or right main coronary artery goes through that particular space, it's called an anomalous path. And what that means is if you do a lot of exercise, your pulmonary trunk or your ascending aorta may enlarge to accommodate for the higher demand or need for oxygen and blood to the systemic circulation, and it actually may compress one of your coronaries if it's sitting in that groove. So young athletes who have heart attacks may actually have this condition, because a young athlete who has trained well shouldn't have a heart attack. They might be exhausted or they might be dehydrated, but very unlikely that they would actually have a heart attack. So it's very important that you know this, because the patient may not know this and we may need to notify a radiologist. Moving further down, you can see more cardiac vessels there. You can see the beautiful appearance of your 2 right pulmonary veins. You can see the ascending aorta. This beautiful streaking cross here is a remnant of the port. The port line sits in your chest. The actual port device sits in your chest, and then the actual port itself has a extension tubing that we have embedded inside the patient's skin. So this is a tunneled port, and the tunneled port gets then tunneled up into your neck and then thread into your jugular vein. And the jugular vein obviously communicates directly with the SVC. So the SVC is where the port line is sitting. And the reason why we have this contrast in the port line is because, sorry, the reason why there's this streaking in the port line is due to the contrast. Because we inject it directly into the port and through the port line, there is probably no blood in that port line, so therefore there is no mixing. So what you see is 100% neat contrast. Something to be mindful of is that not all ports are CT compatible. It's very important that before you use a port for CT acquisition, CT scanning, that you check the compatibility of the CT, of the port, sorry. The reason is if you inject into a port that is not CT compatible, we often do CTs with a power injection device. So that device has a very strong output. And if the port isn't designed for that strong output, there is a chance that you actually might damage the inside of the port, or even worse, you might damage one of the fragile lines inside the port. If you damage the inside of the port, there is only one solution, and that is to take the patient to either an emergency radiology assisted removal of a port, or to theatre if the port has shattered in multiple pieces. So it is a very serious thing. Make sure you check the compatibility of the port, and if you're in doubt, do not use the port. And patients will try to tell you that it is a power port, it is compatible with CT. Don't believe them unless you see proof, please. Okay, so moving further down towards the feet now. You can see here that this is a very... So this location is where the ascending aorta starts to now appear as if it's coming out of the heart, which it is. You will see the left ventricle very shortly. The right atrium should form into the left ventricle, and your pulmonary trunk should come out of your right ventricle. Now, if you look carefully on the image, you can see that there is like two borders here. This is cardiac motion due to the opening and closing of your aortic leaflets. This is very common. A couple of ways that you can go about trying to improve the image quality, or improve the, to reduce the cardiac motion, is to give beta blockers to slow down the heart a little bit, or to scan faster, or a combination of that and do a cardiac ECG trace to image the patient's heart in a particular phase where the heart is at rest for the best chance of not having motion artifact. And that is why cardiac CT is quite an advanced technique, because getting it right does require a lot of knowledge, but also it does make a huge difference to the patient's treatment and diagnosis as well. All right, moving further down, again, that little arrow, so cross in the middle with all that whiteness, is the port line with contrast in it. The left ventricle here, the right atrium, the right ventricle, and the right atrium. So at this slice, this is another one of my favorite slices to show a student, because it just demonstrates all of the physiology that we've gone over, and that you've gone over, over the last few years. Why do I know that this particular chamber is the left ventricle as opposed to this chamber? The reason why I know that this is the left ventricle is because it has a very thick myocardial wall. Remember, the left ventricle is the pumping chamber of the heart. It pumps oxygenated blood from your left ventricle into the systemic circulation. So it needs to be strong, it needs to be robust, so it has a nice thick border. That is a giveaway that that is the left ventricle. And of course, directly next to it must be the right ventricle. You can see the right atrium there, and you can actually see a little bit of motion here, which is probably due to the valve between the atrium and the ventricle. You can start seeing your IVC here, and again, this is just your descending aorta. As we move further down, I'm just going to quickly go through. Same structures as before, nothing very different. However, the esophagus, because it's midline when it starts, but your stomach is very lateral, you will start seeing it move laterally as we progress down. You start seeing your hemidiaphragms, and you start seeing more of your abdominal organs. Alright, so just before we move on to the next slice, I wanted to indicate something very unique about the spleen. The spleen is a very arterial heavy organ, and so it receives a lot of contrast in the early phases of your scan. The spleen is also a very unique structure in that it has a very unique internal structure. So it's very common to see like a wave-like appearance, a mottled appearance. It's also very common to see like this inhomogeneity of the actual spleen itself. So you can clearly see here that this spleen isn't as uniform as the stomach. It has this black splotch and this black splotch and this white splotch here. That is very, very normal on the arterial phase. Alright, moving further down, the liver there, the stomach and the spleen again. The blue arrows point to ascites. Ascites is a buildup of abdominal fluid. So in the stomach we call it ascites. In the chest we call it a pleural effusion. I would not expect you to be able to identify any of your liver vessels without one scrolling and two lots of practice. So I wouldn't even bother trying to memorize them now, because unless you're able to scroll, it's very, very difficult to accurately tell me what these vessels are. You can also see that the stomach there has contrast in it. That is from oral contrast. There are different types of oral contrast, each with their pros and their cons. Some places use gastrographin, some places use isoview, some places use barium. But irrespective of what type of oral contrast you have, it is designed to fill up the stomach and your intestines. Now, again, as we move further down, you'll see the descending aorta as well until it bifurcates into its left and right iliacs. Alright, more Menti quiz time. So back to the Menti quiz. When everyone's ready, we will start a couple more questions. Okay, so now we're going to go through the cross-sectional anatomy of the abdomen and pelvis region. But before we do that, I just wanted to emphasize the difference between an arterial and a portal venous phase. Both of these images are presented the same way, same window level, same window width, etc. Except the image on the left-hand side was scanned at 70 seconds after the start of IV contrast, and then the arterial system, so the arterial scan, was scanned 25 seconds after the start of the IV contrast. You can see that the liver on the left-hand side, or the portal venous phase, has a much more uniform appearance with a brighter attenuation to it, as opposed to the right hand side. And you can also see a lot more veins and vessels inside of your liver on the left hand side as opposed to the right side. And again, we indicate the differences between the thin and thick slices hopefully you've recognized that the image on the right hand side, the arterial phase, is a thin stack of images, and the left hand side is a thick stack. So you can clearly see that because the images on the right are thinner, they actually are more noisy because the computer has less information for it to process the image, and therefore it has this quantum noise that you see throughout. There are things we can try to do to minimize this, but for the most part, it's very straightforward. Less information, more noise. Simple as that. And as a side note, I guess, if you wanted to relate this back to your KVP and MAS for your plain film x-rays, if you don't have enough KV or enough MAS, in the early days you would have learnt of the word called quantum model, and that's because there is so much noise that the processing ability of the crystals or the computer itself is unable to process it, so there's all this hazy, noisy appearance, and that's very similar in CT here. Just some quick mention of some key words. The celiac trunk has the gastric, splenic, and hepatic trifurcations. The hepatic itself then changes its name and course as it moves through the different regions. I just wanted to be clear that sometimes in the textbooks you hear the word hepatic artery, and then in the liver you hear another hepatic artery. The one in the liver is the proper hepatic artery, and the one on the outside is the common hepatic artery. The reason why I'm emphasizing this is because when you do a CTA, you've got to make sure that you see contrast all the way through the hepatic artery. Some people get excited and they only see so they believe that their study is really well done when they can see the contrast in the common hepatic artery, but then they haven't given enough time for it to travel into the proper hepatic artery, which is all the vessels that actually supply the liver. Very important to be mindful of that as well. And again, a quick mention of the non-contrast, early arterial, late arterial, hepatic, nephrogenic, and excretory phases. The non-contrast phase is very useful to see if there are any kidney stones, gallstones, and different calcifications of your vessels. It's also very good for fat stranding because fat will appear a little bit darker on CT because it is not as dense as normal tissue. It has these black streaking, black-like appearances outside of a particular region, and sometimes in the radiology report you hear the word fat stranding. Fat stranding is an indication of inflammation usually, so that's a good sign that the patient might have an infection, etc. The early arterial as opposed to the late arterial, I'm being very specific in mentioning these two because it's very important that you understand these two. In the early arterial naming itself is synonymous with the word CT angiogram. When you hear the word CT angiogram, we're often referring to an early arterial in the sense that we don't want any contrast in any of the organs but except in the blood vessels themselves. We only want contrast in the arterial system so that we can see the blood supply to the liver. When is this important? It's pretty much important for anything that is to do with bleeds, anything that is to do with liver resections, liver volumes, and those kind of things. Is if we wait too long and give and let the contrast perfuse the organ, what happens is it's too bright and it's very hard to sometimes differentiate small aneurysms or those kind of things if there's too much contrast surrounding these aneurysms due to the fact that we've scanned a bit late. So we often would bolus track for these scans to make sure that we trigger the scan as soon as we know there's contrast in those vessels and no later. The late arterial, this is what we often refer to as, well, at my work, we often refer to it as an organ perfusion or an organ arterial, because we want to see how the arterial phase affects the organ. And so therefore we inject through the venous system in the arm, and then wait a certain amount of time to allow the arterial perfusion, and often that's about 40 to 45 seconds. It's a pretty universal time, and it's good for things like HCCs, it's good for things like RCCs, and anything that's really hypervascular. The hepatic phase, or commonly called the portal venous phase, and that's why we have the hepatic proper naming before, is when we don't have as much contrast in the arterial system. So if you have a look at the aorta here, you can see a lot of contrast in the aorta, and you can see not as much in the aorta here. That's because we've allowed a substantial or a sufficient amount of time for the contrast in the aorta to move through the capillary beds, and then to go through the organ, and then return as a venous phase. These are really good for metastases, general abdominal imaging. Remember, the liver is a very large organ that predominantly 70 to 75, depending on which textbook you consult, supplies the liver with blood supply. So because the hepatic vein supplies the liver with such a large volume of blood, it is very important that we image that vessel so that we don't miss anything important, like a hepatic venous thrombosis or those kind of things. The nephrogenic phase is often for the renal pelvises. It's good for upper TCCs, transient cell carcinomas. It's also very useful to see if there are any infarcts in the kidney itself. We've given ample time for the contrast to perfuse through the kidneys. And at this phase, the contrast in the remaining parts of the body should have already washed out. By washed out, we mean it's gone through the liver, been absorbed by some body part, and or excreted by the kidneys. The excretory phase is often 6 to 7 minutes. Some places wait a bit longer. The reason is this phase is really useful to see the ureters. So the IVP is a very important phase, but it does mean that we need to wait a bit longer. So for the most part, an IVP is by far probably one of the longest scans that we do in CT imaging, because it is purely a waiting game. After 10 minutes, 12 minutes, if we still don't see enough contrast in the ureters, in other words, we don't see the contrast moving from top to bottom into the urinary pelvis, so urinary bladder, we may need to repeat the imaging after a X amount of time, but this time we actually might get the patient to lay on their tummies for extrinsic compression to force the kidneys to squeeze more contrast out. That pressure from laying on their tummy prone will push the kidneys and therefore squeeze essentially the contrast through the ureters. In the days before CT to do an IVP, a lot of our predecessors would have done compression IVP, so they would put bands across the table and basically strap the patient down and squeeze the contrast out of the kidneys forcibly so that it can go through the ureters and into the urinary bladder. Fortunately, those days are now gone, and so we now just wait 10-15 minutes, and hopefully with the CT, we'll be able to answer the question. Interestingly enough, sometimes you actually might, unrelated to this, you might do a barium swallow, and then the radiologist might get the patient prone, and to test for reflux or instability of your gastric and esophagus junction, they may put some lead gloves on and actually push on the stomach to try to forcefully push contrast back up. And that will allow them to see if there is any reflux into the esophagus. So there is a rationale for a lot of these old techniques, and it's all to do with physics and just basic common sense. If you push, it's going to go somewhere, and it has to go through the weakest link. And the weakest link is either through the ureters into the urinary bladder, because going back via the vein and via the kidneys is nearly impossible. And in the gastric reflux example, it just has to go up or go further into the duodenum. So moving forward now, I've just named some common blood vessels that I would like you to remember in this order: celiac trunk, superior mesenteric artery, your renals, and of course your inferior mesenteric artery. Those are the four major offshoots of the aorta that you need to commit to memory, please. Alright, so vessels and cross-sectional anatomy of the abdomen. So we're going to start a little bit high and work our way down, and a bit quicker this time. So as we move further down, you again see those normal structures that we saw previously. And I've named a few other structures that I didn't name in the previous example. So as we move further down, I would like you to be mindful that this is actually a different phase to the previous set of images. This is the portal venous phase. So hopefully you're able to appreciate that. One, you can see the hepatic veins, the liver a lot more prominently because it's got contrast in it. It's got this much better homogeneous appearance. And you can actually appreciate the spleen there. Remember what we indicated in the beginning. The spleen is a very hypervascular structure. So in the initial stages of the arterial scan, the spleen is going to be flooded with contrast, and it has those wave-like mottled appearance. But now in this phase, it's stabilized. The spleen has a very nice homogeneous appearance, and it has this really nice shape, which is very normal. Sometimes you might see a splenic cyst, a liver cyst, etc. as well, which should appear as a nice black fluid-filled structure. We're going to move further down. You see ascites still, you see the stomach. Again, don't commit to memory too much about the hepatic vessels, the veins and arteries, until you can practice in front of you with all the vessels and all those things. It's very difficult, so I wouldn't recommend, trying to commit to memory off these slides. Another thing that is of interest to the spleen itself is both the splenic artery and the splenic vein are very tortuous in nature. They have this squiggly-like trajectory from spleen to the respective aorta offshoot or to confluence with the portal vein. So it's not uncommon to see the splenic artery in this kind of appearance here. As we move further down, you can see the gallbladder there with a nice gallbladder wall. And further down, you can start seeing the IVC. Remember, the portal vein system is independent of the IVC. That's why it's called a portal system, because it's not related to the IVC. The portal vein drains all the venous blood from the stomach, from the upper stomach, from memory, the entire spleen, the upper ileum, into the liver for filtration, and then the hepatic veins, the veins themselves of the liver, drain into the IVC complex. So remember that the portal vein itself doesn't communicate with the IVC. The hepatic veins, the veins from the liver leaving the liver themselves, are the ones that confluence with the IVC. Lots of different parts to indicate here. Just be mindful that the pancreas is quite a large structure that kind of appears in different parts depending on which slice you have. So it has a tail, it has a body, it has a neck, and it has a head. Pancreatitis often causes fat stranding. So this patient, if you can appreciate some slight haziness through this blackness here, this blackness is mesenteric fat. And so this is just fat stranding, increased inflammation that you can see through the pancreatic region there. This is the aorta, the splenic vein. Now remember, because it's a vein, it must cross the midline. In this case, instead of going to the IVC, it will go to the portal vein, or it will confluence with the portal vein. As we move further down, you see the celiac trunk there, which is the first offshoot of the descending aorta that you should know of. The splenic vein, the pancreas, the portal vein, and you see the different parts of the stomach there as well. Now, obviously, it's a bit challenging. We've missed a few slices in the middle. I've gone from the celiac trunk straight to the SMA, but obviously there'll be a few slices in between. I just haven't indicated it. Anything that is gas-filled with a nice borders like this is probably going to be some form of bowel loops. In this case, because it's still quite high, because of the caliber of this particular loop, and because of its location on the spleen side, it must be the splenic flexure. The pancreas coming across here, this is a pancreatic cyst, a portal vein here, and obviously this is the stomach as well. Okay, so you can see there the SMV, the superior mesenteric vein, has confluence with the splenic vein, and that will eventually confluence with the portal vein as well. Now, the renals actually drain into IVC, so you can see here your renal vein in this slice. Sorry, the renal vein in this slice, you can see it confluencing with the IVC here. The left kidneys, the SMA, the descending, and you can see your right renal artery here as well. So as we move further down, again, you just see those structures we mentioned, and you can clearly see the left renal vein crossing the midline and eventually forming or confluencing with the IVC. You see ascites throughout this patient. This patient has ascites, so there could be many reasons why. Without the history, it's very hard to identify it, but it could be drug-related, it could be cardiac-related, it could be cancer-related, many different things. Again, very similar to the previous slice, so we'll just move on to the next one. It can get a little bit busy at this level, so when you're learning, I would recommend picking a vessel and just scrolling up and down to follow it. Remember, because these are vessels, it doesn't just go up or go down, it might go up and down, or in and out. So you may lose it a little bit, but you may need to then scroll the other way to see where it goes. Okay? You see your descending colon there, your duodenum loop. You can see your descending colon in this really strange appearance. It's because you're looking at it dead on like this rather than cutting it side on or something like that. SMA, you can see there, your duodenum, more ascites, etc. Nothing very interesting in this slice besides those we've mentioned before. Again, at this level, you start seeing your bowel loops on the hepatic side. The first bowel loop you see is called the hepatic flexure, and obviously you see contrast in your bowel loops there, and that is why sometimes oral contrast is really useful, because the oral contrast makes it very clear that this must be large bowel, and this bowel here may not be related to this bowel at all because it doesn't have oral contrast. If they're next to each other and completely connected, I would expect the oral contrast to have moved from this region into the actual hepatic flexure. So that's a good indication that those two are separated. At my place, we often give oral contrast because the patient has gynae or endometrial kind of female related cancers, and so with all those compartments and components downstairs, without the oral contrast, it can be challenging to see where bowel starts, where bowel ends, and where other structures start and where other structures end. So the oral contrast is useful for that as well. Moving further down, of course, the hepatic flexure will form the transverse colon. Transverse colon will then form the splenic flexure. Sorry. I wanted to point out a couple of the muscles here. I just find them really interesting to say because, you know, the left and right psoas muscle, I think it's very nostalgic because when you first learn x-rays, one of the first things that you learn is to identify the left and right psoas muscle on your abdomen x-rays. If you can see the left and right psoas muscles on your abdomen x-ray, is an indication or a good indication that you have adequately exposed the image. The reason is, remember that exposure or the adequacy of density is related to all of the densities that you're meant to see. So we're meant to see the soft tissue, we're meant to see the contrast, we're meant to see the bone, etc. But if we can't see that, then there may not have been enough KVP, MAS to be able to adequately demonstrate the densities. For the most part, it will be MAS that is the problem because MAS is by far the highest controlling factor of density, and conversely, contrast is heavily influenced by your KVP. So in CT, we also have that problem. It's a balancing act. We need a high KV to be able to produce a really all-rounded, high quality picture. But if it's too high, the image might be a little bit grey and flat. But if it's too low, we may not have the penetration ability to punch through the thickest anatomy part, and therefore we might get quantum model as well. So it really depends on what it is that we need to fix. And I'm so sorry for the tangent. I do like to go on tangents sometimes. Now you can see the yellow arrows are pointing to the mesenteric vein, arteries / veins. Not sure from this picture. Again, a couple of the common things we've mentioned before. Keep going down further. So back to the previous slice, the descending aorta here will now bifurcate into the right common iliac and the left common iliac, and the internal and external oblique muscles you see there through your rectus. And you see some of the bowel loop, you see your mesentery. It's very common to have this appearance throughout your mesentery because some of this is extra fat, some of this is just normal fat, so it has various appearances on CT. And we move further down. Remember, your iliacs will bifurcate into your internal and external iliacs, your common iliac vein and your right common iliac vein will eventually appear as well. So just moving further down, and you can see here that your iliacs have already bifurcated on the right side. So you can see the internal and external iliacs I've mentioned there. Remember, these are the same vessels. So later along the track, the iliac will then become the femorals. You can see the uterus there. You can see the left and right internal iliacs. You can see just those major vessels that we've indicated there. Sigmoid ascites, left external iliac, right internal external iliac as well. Moving further down, more ascites, or sometimes we call it a collection in the bottom half. Rectum, sigmoid. Moving further down, more muscles, psoas muscles, sigmoid, etc. Urinary bladder, rectum, bladder, part of the uterus. Sorry, my apologies. This is not the uterus. I don't know why I called it the uterus. The thing in the middle here is a loop of bowel that has come on itself like this. My sincerest apologies. Now that if you think about it, the uterus shouldn't be that high anyway. So a lot further down here is the uterus. The peduncle arteries and veins are there. The acetabulum, the coccyx, and the femoral head you can see there as well. So, yeah, down south, it's just a lot of muscles. So the major points that you should get out of this is probably in the pancreatic, liver region, and maybe around the kidney regions. Anything further than that, the common things that you might point out are just the bifurcations, the iliacs, etc. All right, I think this is the last Menti quiz, and I've got one more small presentation for you guys, and then we'll call it a day.